your attendance certificate via email. I want to again thank Pulsara for sponsoring today's webcast. Now it's my pleasure to introduce our speakers today. Stephen White is a commander at Austin Travis County EMS in Austin, Texas. He's originally from West Texas and trained at Texas Tech University Health Science Center. He's using his 25 years of experience in EMS to help to develop new programs with the Collaborative Care Communications Center. Dr. Carlos Navarro graduated from the Autonomous University of Medical Sciences of Central America. That's in Costa Rica. He completed his family practice residency through the Austin Medical Education Program at Breckenridge Hospital in Austin. He is the medical director of Care Valley Optimization, Austin Market WellMed Medical Management. And with that, Stephen, the floor is yours.
Thank you very much. I want to say thank you to Jim's and to Pulsara for giving us this opportunity to talk about some of the awesome things that are happening right now in our industry and being able to present our story to you. I get pretty excited about these things, so if I get a little animated, forgive me. Don't try to adjust your screen. My face really is this red after a quick trip to the beach this weekend. But basically, I want to set kind of the stage for this webinar today. So many times we come into these trainings and we're talking about our high acuity patients. We're talking about our STEMIs and our strokes. We're talking about our severe trauma. Today, we want to flip it around, flip it on its head a little bit, and really focus on our low acuity calls. The roles of EMS are changing constantly. And as we kind of accept our role in this modern healthcare system, we're going to have to switch our focus from those high acuity calls to our more frequent and higher percentage of our call volume, which are these low acuity calls. So as we start this conversation, as we go through this presentation, the mindset that I want you to have is that we are not talking about really sick patients. We are talking about the lowest of the low acuity. And honestly, I think if you went to any paramedic and you put him in a situation where it was a STEMI or a stroke, something that actually involved life or death, he would be pretty comfortable with that. But you give him something that maybe is I don't know, low acuity with something complicated that has maybe a social work aspect or whatnot, that's when a paramedic really becomes uncomfortable. And his most comfortable thing to do is just take that person to the hospital, which kind of punts it on to our healthcare system. So what we want to talk about today is how do you turn your employees in your department into force multipliers? You're always going to be asked to do more with less. That's never going away. And we really encountered that whenever COVID hit, March of 2020. That first COVID surge really was a wake-up call. And we identified that we needed an extra layer of triage in the process beyond our triage system and our 911 call center. And we needed to be able to stratify those calls as they came in because we needed to be able to at least give a recommendation of PPE to our providers when they arrived on scene. But what we found is through that triage and that stratification, we could actually provide services while still having reduced EMS contacts and a reduced number of transports. And for the first time in our industry and in my department, we found ourselves where you had to be sick enough to go to the hospital. You had to meet certain criteria because our healthcare system was overloaded. And so this started a process that we call PINTS, which stands for Paramedic Initiated Non-Transports. But it really set us up for being able to start mitigating calls with maybe something other than an emergency room or other than an ambulance. And then right after COVID, we had 2 hurricanes and we had the ice apocalypse. Here in Texas, we're not really used to cold weather. We had, a week of freezing temperatures with no electricity. And we keep finding ourselves in the same situation over and over again with all these crises. We have a higher call volume, we're in a staffing crisis, and we have an overloaded hospital system. So we had to come up with new inventive ways to deal with these three big problems. And what we had identified with going through that stratification process during COVID is that we had more options than we thought. As these crises develop, what we find is that more people are using 911 as the entry point into healthcare. The role of EMS, where we're only dealing with life-threatening emergencies, has evolved to now we are part of the healthcare industry and part of that whole healthcare system from start to finish. We really have to start focusing more on these low acuity patients and how can we help them the best. And so we've kind of come up with this motto, and it's called the right resource at the right time for the first time. So we started a team, and we call it the C4. It stands for the Collaborative Care Communication Center. It's a team that ranges according to whatever problem we're trying to solve. During a high crisis moment, like a surge in COVID, it could be up to 12 people. Or now, as we're coming out of COVID, it can be as small as 6. But basically, this is a team of problem solvers. They are very experienced. They've usually been with our department anywhere between 10 and 20 years. They have a lot of clinical experience, and they're chosen based on their ability of good decision making. And so what we've done is we've empowered them with as many tools as we possibly can to deal with low acuity patients. What they have done, and it's been a very team-driven project, is that they have developed pathways for patients. We have pathways for low acuity patients that range anywhere from alternative transport to treat in place to telehealth to long-term care, post-acute management, durable goods, home health, hospice. All of these pathways, they're able to get patients the treatment and the care that they need right then, even though it may not be an emergency room. Now, this team has kind of been injected with a really good idea that's come out of CMS and Medicare, which is the ET3 model. If you're not familiar with the ET3 model, it stands for Emergency Triage Transport or Triage Treatment and Transport. It's an initiative that Medicare started to try to decrease the number of unnecessarily hospital transports. The advantage that ET3 has given EMS, especially in my community, where we really focus on equity, if I have to offer it for someone of Medicare age, I'm going to offer it across the board to the entire community. Those principles that CMS has come up with has really guided us in implementing these new ideas and these new pathways to treat people outside of the emergency room and trying to get them the best care the first time. So the roles of the C4 when it comes to dealing with these low acuity patients is they're kind of the clearing center, the clearinghouse. They manage all of the communication between the different entities. We set up these partnership agreements. Some of them are through ET3 and some of them are not. But in these partner agencies, we're able to refer patients and get them care and services that otherwise they wouldn't normally have. And we're able to do that outside of the emergency room. That really frees up the healthcare system to deal with patients that really need it. This idea really works. It works really well. And when we talk about resources and where you want to put people and your time and your money, this is the first time that you're hearing about an idea like this and you're an EMS administrator, I wanted to give you a perspective on how this affects patients. Not only does it affect the patient care, does it affect the department? Does it affect the primary care physician? Does it affect the hospital? So what I did was I invited one of our partner agencies, Dr. Carlos Navarro. He is the medical director for care value optimization. Basically, Dr. Navarro is the innovation for his clinic, and he's been working with the C4 now. It's been over a year. We meet about every other week, and we discuss new ideas. We review patients that we've interacted with. And I wanted to ask him to come on, and we're going to present a case study where we kind of look at a patient in this program from as many different angles as we can, and not just the EMS perspective, but he can offer the primary care perspective as well. We heavily leverage our technology in making this happen. And so he can also speak to interacting with that technology and how it works. So if you would please welcome Dr. Carlos Navarro.
Thank you so much, Steve, for the kind introduction. It is a pleasure to be here. This is like yourself. I can talk about this all day. I get excited about all these new initiatives that we're working on. First, a little bit about myself. I'm a family physician by training. In addition to seeing my patients, I have the privilege of working with a team that focuses on enhancing the patient's experience of healthcare, improving population health, and reducing low-value care, which fits right in with what we're talking about today. And like you said, when I was preparing for this today, it's been a journey, right? We're live now. We're seeing cases, but we've been working on this in collaboration with Travis County EMS for a while now, and it's good to see it finally moving and progressing. And now we're talking about, okay, what's next? What else can we do with this? So, like I said, very excited to be here, and we can go ahead and look at that case that we picked to show today. It's a very basic case, but it showcases the importance of the program. So this first patient that we're going to present is a 65-year-old female patient of one of our clinics here in Austin who has COPD, cerebral palsy, peripheral vascular disease, major depression. And she decided she was alone at home and called EMS around 9 a.m. On a weekday. Her complaint was that she had dropped a jar in her leg 3 days prior. Her leg was hurting. It looked swollen. I had an open wound and didn't know what to do. So that's pretty common, right? Like Steve mentioned, most of the cases that we've handled are very basic things that we should be able to handle in the outpatient clinical setting and really should not be going to the emergency room. So let's stop there and see how we handle that before we started with the program with the next slide. So Steve, walk us through this.
Yeah, I wanted to do a compare and contrast on how we used to deal with a patient like this. This would be one of those situations where maybe a paramedic wasn't comfortable because they're most comfortable in high acuity situations. So the only option at that, 2 years ago would be to put that patient in the ambulance and take them to the emergency room, when maybe that's not the best course of action, And so I wanted to kind of take a look at what would happen to this patient 2 years ago, and starting with the patient care. So the patient is going to be placed on the stretcher. They're going to be taken to the hospital. They're going to be seen by a doctor, maybe some x-rays. And then at that point, the doctor is maybe prescribe an antibiotic if it's infected, maybe prescribe some pain medicine if it hurts. And then they're going to be given the discharge instructions to follow up with their primary care physician. From an EMS standpoint, that's going to take an ambulance about maybe an hour and a half when you consider the response time, the scene time, transport time, turnaround time. That's going to take the ambulance about an hour and a half to do. That patient's going to get a bill for the ambulance. They're going to get a bill for the hospital. They're going to get a bill for the doctor seeing them. And when they come out of that emergency room, they're really not going to be that much better off than when they went in. They still have to have the follow-up care. They still have to see their primary care physician. And Now they're out of pocket, a substantial amount of money. I was going to bring in some figures to kind of represent that, but the more I looked into it, every city is different, every hospital is different, every part of the country is different as far as to how much they charge you just for walking in the door. In this particular case, there would have been a burden on that healthcare system that maybe 2 years ago could have been easily handled, but not so much today. I wanted to ask Dr. Navarro, 2 years ago, if you had a patient that was coming out of the emergency room with follow-up instructions to meet with their primary care physician, what kind of challenge do you face now?
Yeah, so this is, very critical. So like you mentioned, this patient would go into the emergency room, and most of our patients in our clinics are seniors or have Medicare, Medicaid, disabled. So they have a high level of medical complexity, a lot of chronic illnesses. So if I put myself in the shoes of that emergency room provider, right, they don't know that patient. They don't have all the medical information, all the clinical data, the chart information from the clinic. And he doesn't have a solid way of discharging that patient home safely. Maybe not in this case, right, but other cases where he's kind of on the fence about, do I put this patient in the hospital for an observation or do I send him home? The hands of the emergency room physician are kind of tied there. So that's what we're facing, right? It's just limited information, complex patients, and it's clogging up the system.
Do you ever run into situations like in this instance where it's a very low acuity call and they're calling 911 because that's pretty much their only option? Looking at this case, the crew actually documented in the narrative that she tried to call an Uber, but the Uber said that they wouldn't take her if she wanted to go to the hospital as a patient. So now the patient's been discharged home. They're supposed to do follow-up care. How are they going to get to their follow-up care? At some point, it may be that they call 911 back because that is their only point of contact with healthcare.
Very true. And another scenario that ties into that, sometimes everything works correctly. They get a prescription, but they don't have a way to get to the pharmacy to fill that prescription, or the prescription, the antibiotic that was prescribed is not on their formulary. They don't fill the antibiotic. They wait another 4 days, another call to EMS, back to the emergency room, right? So you can see how it kind of waste in medical care carries on. And there was no contact with the office of the primary care physician, so they don't even know that the patient went to the emergency room. So it's up to the patient to call and to schedule that follow-up appointment. So very uncoordinated care.
Do you have access to their records from the emergency room as their primary care physician?
In our care model, WellMed, that's the hallmark of what we do is to coordinate the care. So we do have a team of folks that look for the census of the emergency room, the hospital, try to get those records and notify the primary care provider that one of our patients has been in the emergency room. So we proactively reach out to the patient as soon as we know that they're in a facility of any kind. So we do have that. It's something pretty unique to WellMed and in previous positions I've held in the private fee-for-service world, where a lot of my colleagues practice in. That's not the case. You just don't know when a patient went to the emergency room unless they call the clinic and ask for an appointment.
All right, let's take a look at the new way we do things. Look at that pretty Audi. All right. So we're gonna kind of break this down in small steps. So exact same patient, exact same scenario, except this time when the ambulance crew gets on scene and they identify that this is a low acuity patient, they also identify that this is a WellMed patient and they have options. So kind of the operational scope of this is that the crew would call the Collaborative Care Communication Center, the C4, give them this information, and then we would use a piece of our technology. We're using Pulsara And what we would do is we would notify Dr. Navarro that we have one of his patients. And we can do that through Pulsara. So he doesn't have to be reliant on a phone call or a text message or an email. It's an instant notification. And it's a notification that goes out to not only Dr. Navarro, and Dr. Navarro, you can kind of comment on this. How many people will that notification go out to in your organization?
Yeah, so this was a critical piece when we were starting to discuss the project, is how do we communicate with the primary care provider, with our nurses or our clinic supervisors, that there's potentially a patient coming in. So we built this profile into the app, and you can, add people as you see fit. We have an account administrator, so we have all of our primary care providers listed on the app, so they get the alert. And so with one activation, you can notify all of our teams in all the clinics, and it's instantaneous. So they can see the patient name, date of birth, a little bit of clinical information, vital signs, and they can quickly look in their electronic health record and see, okay, that's my patient, and jump in on the call and say, okay, how can I help? What can I do? He's one of our patients.
So once that ambulance crew activates this process and the Collaborative Care Communication Center starts the Pulsara app, at that point, you can have video conferencing between all parties. Now, we've been doing this for a little while. We have over 300 telehealth consults in our pocket now. And I cannot stress enough the importance of being able to have that visual connection, not just with the doctor and the crew on scene, but the patient as well. And when you get all three people on a video conference call together, it brings up a very interesting point, which is this is a completely new idea that most people are not going to be comfortable with. And so getting consent, getting the patient's agreement that doing something different will work for them, the video aspect of that is a huge, huge deal. We've done it over the phone, and we've done it, using Pulsara, but just voice. But really, it's the video that makes the huge difference. It's the video that makes people feel more comfortable. So the C4 got everyone together, activated Pulsara, and on this specific patient, Dr. Navarro picked up. And I just wanted to get Dr. Navarro's perception of the interaction with the patient in this situation.
Yeah, so in this case, it was great that we're able to, hey, we can send you right now, there's a picture of the wound. I was able to assess there and corroborate, yeah, this is something we should definitely take care of in the clinic. At the same time, I was communicating with the primary care provider for that particular patient and updated him on, hey, here's what's going on. One of your patients has a wound. This is what's going on. Said, sure, I'm ready to see her. Happy to work her into the schedule this morning. And within minutes, the clinic administrator, the staff in the clinic was ready, because that's another thing that was important to us, to not disrupt the flow of the clinic. So notifying them in advance that there's a patient coming lets them know, gets the staff ready, so there's no surprises. Oh my God, what's an ambulance doing here? Normally the process is the other way around. We call from the clinics to send the patient out, not to accept the patient. So that was a culture change for us. In this case, it worked very well. They were ready for the patient to come in. It was seamless. The patient was seen, wound was treated, antibiotics prescribed. And another very important piece, a lot of our patients, she called EMS in the first place because she didn't have transportation. So how is she going to get back home? Well, we know that from the minute the call comes in that she's going to need transportation back. So we have what's called comfort care. So we have a transportation system, drivers that can take our patient safely back home after she was discharged. And they get notified as well that there's a potential transport happening, because there's logistics behind that, right? How to get that patient back home. We don't want them stranded in the clinic for hours waiting for an Uber or a cab or anything like that. So the experience was really positive for the staff, for the primary care provider, for the patient. So a success story all around. She had follow-up a couple of days after her visit via phone, and the wound was doing better. No other visits to the emergency room since.
So let's go back to the point where you're having the conversation with the patient and the crew. What would happen if you didn't agree that this patient was appropriate for your clinic? Let's say you wanted to take x-rays, but maybe your x-ray machine was down, or perhaps because you know of her past medical history, because you have access to all of her records, what if you didn't agree that the clinic was the most appropriate thing? Can you kind of walk us through what would then happen?
Yeah, and that brings up another great point, right? I think the beauty of this is just the opportunity to communicate and collaborate, because we have EMS who are highly trained, highly skilled at what you guys do, which is triaging and ensuring that the right patient goes to the right place. We have the primary care providers in their clinic. We have the emergency room doctors in their setting, but we're not talking to each other. So this, to me, is the critical piece of this, is just having that on the spot collaboration, and kudos to you and your team. The interactions between myself and all the other providers that have used the app have had a very positive experience. Everybody is happy, upbeat, and excited to collaborate, which was one of the worries with the program, right? Is there going to be some pushback or whatnot? So that part has worked beautifully. And to answer your question, it has actually happened, not in this case, but we've had other cases where I participated, and during the call, the vital signs changed, the clinical scenario changed, and then we said, no, you know what, this is better if we don't take it to the clinic. Let's change course and go to the emergency room. It gives us an opportunity to, even though we're not going to see them in the clinic, to improve the outcome of that case, because I can request of your crew to please take this patient to this facility, because I can contact our teams over there. We have our own hospitalist team, and we can notify them ahead of time that, hey, a patient is coming over to the facility. Don't go to the other facility, wait for them to arrive, and they can go and meet them in the emergency room and expedite their evaluation, which we have a lot of data on our side that shows that if our team is involved, our case managers, our nurses, our hospitalists, the coordination of care is a lot better. The average length of stay in the hospital is shorter. The rates of readmission are lower because they know how our system works, and they communicate with the PCP at the time of discharge, ensure they have all their prescriptions, the appointments for follow-up are made. So that's the beauty of this, is even if they do go to the emergency room, just having them go to that facility where there's a team waiting for that patient makes a huge difference.
All right, we're moving on. I want to try to keep your attention for about 10 more minutes. I want to talk about the impact of a program like this and get Dr. Navarro's opinions on a couple of things. The Pulsara platform definitely makes this easier. Without the technology, this would be almost impossible. And if we're looking for better community relationships, these partnerships, like with Dr. Navarro and my team, the partnerships that we have with other providers as well, it's creating a better community experience for everyone. Trying to get them the right resources is very difficult to do on a 911 call if you can't get a hold of somebody. You know, if somebody's not answering their phone, or you have to wait on a reply email. So using Pulsara and using this technology definitely helps with that, because it's more instantaneous. Just because you can push one button and it'll go to multiple people, right, until somebody answers. As you can see in this situation, this patient didn't have to be transported to the hospital. She got excellent care. That was a reduction on the hospital system. You know, in this situation, everybody wins. There are some pitfalls and challenges. Like I said, you have to heavily leverage your technology. We use about 4 different platforms in the C4. Pulsara is what we use for most of our communications. Now, there are some features that we are implementing that would make a really big difference. For instance, if Dr. Navarro had had the same conversation with the crew, but decided that the patient did not require transport at that time, for whatever reason, the patient didn't want to go, that wasn't necessary, and he wanted a follow-up of that patient, or if one of my medical directors that's doing a telehealth with a patient wanted a follow-up, we can use this platform to refer patients for follow-up. And we can track that. We can see who picks it up and who doesn't. And that way patients don't fall through the cracks. One of the other challenges that Dr. Navarro mentioned was transportation. You know, we're transporting these patients to a clinic or sometimes a rehab facility, sometimes a pain management clinic. How do they get home? So you kind of have to set up that return visit transportation and think of those logistics as you're working through the call. And then this is the big one that I really wanted to talk to Dr. Navarro about. This is a new concept. If you're on this webinar and you are a paramedic, I'm preaching to the choir when I say we have been trained and conditioned that all patients go to the hospital. And we get really uncomfortable when we start feeling like there's a liability if we choose to do something else. And this culture change with being able to just try to get the right care and the right resource to the patient, even if it's not an emergency room, is going to take a huge culture change and a huge buy-in. And I know, Dr. Navarro, you experienced the same thing with your providers, right?
Correct. Yeah, this was, like I said, we've been working on this for a while, and that's been one of the big barriers, because there's always been this mental block, right, that no, EMS, ER, it doesn't work the other way around, right? A lot of the providers were like uncomfortable with, oh, I don't want to receive a patient that's, unstable or crashing or et cetera. So we had to really work on that piece and explain to them that you guys are the experts in triaging, and you're not going to bring into the clinic anybody that's in that condition. And that took a couple of cases and so kind of socializing the success we had and how simple it is, and its basic cases, things that really belong in the outpatient setting and not the emergency room, to get the providers and the staff and everybody comfortable saying, yeah, well, yeah, this makes sense, right? It's okay. This is the right thing to do, to see those patients here in the clinic. And I would add, a lot of the patients were scared to go to the emergency room, still are, in the middle of a pandemic, senior patient with a compromised immune system shouldn't be going to the emergency room, right? We should try to keep them safe and keep them in the clinic.
Yeah, my message to the field providers in my organization is the biggest change with this idea is something that they have earned. That physicians, whether it be physicians like yourself or physicians in the emergency room or the physicians with medical direction, that paramedics have now kind of found their place in the healthcare system, where they have earned trust from these doctors, where when you're talking to a provider on scene, or when my medical director's talking to a provider on scene, that they actually trust the paramedics' opinion and what they're seeing, and the diagnostics that they're able to do in the field. And so this uncomfortable feeling of I have to take everybody to the hospital should actually be a proud feeling, because it's something that they've earned. It's the respect that they've earned. What has been a change in your view of EMS since we started this whole relationship over a year ago?
Well, I can tell you from my own personal experience, even through my training and all that, there's always been this invisible wall, right, of whenever you call EMS to come in and pick up a patient, and because they need to be taken to the hospital, that it's okay, they're off my hands now, no, you deal with it. And there was very little communication. Now, I really enjoy the interaction, and the providers that have participated in the calls really get that sense of teamwork and working as a unit to help the patient out. And they're comfortable having those conversations. And it comes to mind the fact that we set it all up, we were ready to go live, and we were just not getting any activations. And I think in my mind, one of the things that really helped was to actually go and visit one of your crews that was, sadly, there were a block and a half from that clinic for many years, and we've never met them. So we went and had I think they brought some snacks or something and interacted, and the lead physician for that clinic said, "Hey, yeah, we're down the street. It's okay. We really want to do this. We really want you to bring patients over." That kind of broke the ice and started the whole thing, and we started getting our first calls when they said, "Yeah, we really are going to do this." It does work.
Yeah.
So I think it's the human connection really that's a big success of this. I know we're talking about technology and this and that, but at the end of the day, it's about human interaction, communication, and everyone focusing on the same thing, which is putting the patient in the middle there and making it the focus of the conversation.
I agree. And I think that the culture change is ongoing. So how do we take some of the things that we've learned in this process and make it scalable, right? So I think that if you're watching this webinar and you've kind of heard our stories and the things that we're talking about, because we're kind of talking in very broad strokes, but I think you need to pick probably 2 or 3 things that you want to focus on. What is it that you want to impact? Do you want to impact how many number of calls your crews are running? Do you want to impact your patients, the hospital system, your turnaround times? Any one of those could benefit from implementing some sort of treat in place model, okay? When we talk about treat in place, we talk about telehealth. We talk about actual treat in place to where you're going to treat that patient on scene and then clear the call. And then alternative transport we throw in with treat in place as well, like a transport to Dr. Navarro's clinic. Where you're really going to see the benefits of implementing a treatment in place, I don't have the same problem with my organization right now that many across the country do, which is really long turnaround times at the hospital. I will be on intervention, phone calls, and people will say, we have no units available and we have 3-hour hold times at the emergency room right now. The impact to your system, if you implement a treat in place program or an alternative transport program, is you are going to save that time that your crew is tied up waiting to hand over patient care at the emergency room. If you do that, you'll also impact your field crews because they're going to be freed up for calls, and it's not just the hold times at the emergency room. I want to kind of put it all together. It's the transport time, the hold time, the turnaround time, and the return time to get back to the district, okay? We have found in our tracking that if we are going to do a telehealth or a treat in place, that our average scene time only increases by 10 minutes. 10 minutes is a huge difference than hours on the back end with transport hold times and return times. So you can really impact the day of your crew, the availability of your crew, and at the same time, you're really affecting your hospital system and your healthcare networks because you're not taking these low acuity patients and making your problem of turnaround times at the hospital worse by just continuing to bring patients that probably could be served better elsewhere. So what is the force multiplier? Well, the force multiplier for me is this C14. If we can handle a high percentage of low acuity patients, and in my system, we use treat in place, but we also use single provider response units. We also use physician assistants and nurse practitioners, social workers. We have a lot of options available to us that if we can handle those low acuity patients, if we could set a goal of 15% of the daily call volume and handle those lowest of the low acuity patients, then I have 4 employees who would normally be staffing 2 ambulances, handling the call volume of 5 ambulances. So suddenly, with the same amount of workforce, I'm able to handle twice as much volume, just because we're doing it differently. And it's taken a lot of getting used to. It's taking a lot of mistakes being made. And hopefully we can do another one of these webinars where we really break down the nuts and bolts of how to do it. But if you're sitting here wondering, does it actually work? Yes, it actually works. And this model can be an absolute beast if you want it to be. We have tested it. We're in operation every day. But in the last COVID wave that we're just coming out right now, in the middle of August, we went full in. We were pretty much tasked with trying to relieve the healthcare system, take some of the pressure off of the crews. Our crafting site, our staffing crisis was getting worse. Our crews were starting to get sick from COVID. So here's what we were able to do. Using these treat and place models, using these alternative transports, using telehealth, we were able to keep over 400 people out of the emergency room during the last wave. And that's over about a 40-day period. That's a lot of people. Over 400 people makes a significant difference in your healthcare system. It also makes a significant difference in your department and your agency. So what's a realistic expectation? Well, that kind of really depends on your location and your size. You know, for my department, we consistently run 500 calls a day, and we have over 40 ambulances. So for me to save 400 people from being transported to the ER is pretty simple. But if you're in Butte, Montana, and you only have a handful of ambulances, but maybe your transport times are an hour, 2 hours, you know, if you could have one treatment in place during that shift, that could save you considerable time. Just implementing one of these small treat in place or alternative destinations could really have a big impact on your department, just kind of depending on what your situation is. So what does the future look like? Well, we're always going to be asked to do more with less. And we're always going to be in a position where staffing is going to be difficult. I don't see that that's going to let up anytime soon. Finding paramedics, if you've tried to hire one lately, it's extremely difficult. So I really think that the future is, if you're going to implement a force multiplier team, if you're going to have a collaborative care unit there in your department, you should really start looking at multidisciplinary members of that team to try to cover kind of as many aspects as you can. As you start developing these pathways to help with your patients, you're going to need subject matter experts with them, whether it's telehealth, whether it's mental health. If you can find alternatives to transporting your mental health patients to the emergency room, whether it's a mental health facility or a mental health responder, whether it's we also offer a 24-hour mental health telehealth option, you know, then you can really save a burden on your healthcare system. And for that, and just so that we're as well-rounded as we possibly can, our collaborative care unit, I mean, it's called the collaborative care unit. We work with social workers. We work with police officers. We work with durable medical. I mean, we bring in as many people as we can into these agreements, and we try to set them up on Pulsara so that if we need something, it's literally a one-button push and someone gets notified. And then we can track who sees that information, where that information goes, and how it comes back. this is something that you can do that doesn't necessarily require Pulsara, but it definitely does make it a lot easier. So Dr. Navarro, do you have anything else that you would like to add to this? Any insights from your perspective?
No, I think you summarized it very well. Like I said at the beginning, I think this is only the beginning. I think there's a lot of potential. Hopefully we conveyed that to you here today, that this has been a very positive experience for everyone involved. And I would like to see this expand. We were here at WellMed in Austin, the first place to try it. Now it's already expanding to our San Antonio market pretty soon. If they haven't gone live yet, I think they might be pretty close to their go live date. So I can see this as a great opportunity to improve patient care, improve collaboration with our, all of our even specialists, ER departments, EMS, everyone needs to collaborate if we're going to make this work more efficiently. And I think this is just the beginning. So I'm excited for the possibilities.
All right, let's take some questions and answers, or some questions, and we'll try to give answers.
No problem. Yeah, so that was a great presentation by both of you. Thank you for coming on today. First of all, I'm so glad that you're seeing success with your ET3 program, and hope it can be replicated. So we have a lot of questions. Let's dive right in. Is the receiving facility, if the receiving facility is not an ET3 destination, how do they participate in the model? Or is there a different option you're exploring through a partnership with that facility?
Yeah, the ET3 does have a partnership agreement that's extremely specific. We have gone beyond that because we have to, equity is very important in my community, with my city council, with my department leadership, that we are able to offer that the same service to everyone, regardless of age or whatnot. So we're able to set up partnership agreements outside of ET3 because we have these equity requirements. We have found these not only just by going out and getting them to participate, because we've come into a situation where we need a walker, and we just start beating the bushes looking for a walker to provide for this patient. It's that kind of tenacity that gets you these relationships. That's how we got post-acute medical. That's how we got hospice. Basically, a situation would present itself where we had a need. We would start trying to fill that need. We would use other resources inside the city. We have community health paramedics. We have mental health professionals, and so we would ask them, who can we call? Who can we ask? And it's through those interactions that we've built up these relationships.
For sure. And earlier you mentioned you have 300 people plus signed up for telehealth. The questioner wants to know how many people have accepted and followed through with the telehealth service.
Yeah, we do telehealth a little bit differently, and actually it's forever evolving. I have the luxury of having access to fantastic medical direction. They are very involved in this program, and they participate in this program. When I talk about treat and place options, I can literally send a physician for sutures. I can send a physician for peg tube replacements, for Foley replacements. I can send a physician on scene for whatever treat and place pops up. But it is also our medical directors that are providing our telehealth services right now. And we do our telehealth services just like we do with Dr. Navarro when we are transporting to his clinic. We're doing them on Pulsara. And what that allows us to do is when that medical director pulls up the Pulsara notification, they can see the vital signs, they can see the EKG, it's very visual for them. And then through the video feature, they can see the patient themselves. So we have an internal telehealth. The problem that we've run into with this last COVID wave is that the response, once the crews bought into this concept that not everyone had to go to the emergency room, the response was overwhelming. And my medical directors were up 24 hours a day, 7 days a week, answering Pulsara and phone calls for telehealth consultation. It's to the point now where at some point right now, we're exploring an external telehealth option, right? But it's when you talk about consent into the telehealth option, that video feature is significant. The ability to see the doctor has a significant effect on the patient, and then the ability to see the patient from the doctor gives them a comfort level that's really important.
Right, without a doubt. And are bed-bound patients accepted into clinics? And if so, are the EMSs tied up for transport to bring them back home?
So we do not, what do they call it? Turn and burn, where you take the patient to the clinic, you wait for the evaluation, and then you bring them back. When we do an alternative transport, we treat it just like we would a 911 call, which means we'll take you there, and then an ambulance is not going to come back and pick you up. A 911 ambulance. Now, if we do transport a bed-bound patient to Dr. Navarro's clinic or any one of our other partners, a non-emergency ambulance can come pick them up and take them back. Part of that logistics is part of this process, to where those questions most of the time have to be answered before you transport to the clinic, because the patient is going to be asking, how do I get home? When you're telling them, we're going to take you to the clinic, we're going to let you see your doctor that knows all about you, you have that conversation on the phone, they're going to ask, how do I get home? The emergency rooms have a pretty good system, whether it's cabs, Ubers, non-emergency ambulances that'll be transporting back. And so we kind of glean off of that. We take, the model that they use, and we use it as well.
And for the crew, how do they know the patient is part of the WellMed PCP/clinic?
Oh, okay. Yeah, this was a hard challenge and continues to be. In my community, we have several large clinics and payer networks, healthcare networks. And there really is, we have searched high and low for a technology solution to this, but literally it comes down to picking up the card and looking at the logo and seeing that they are a WellMed patient, or, just starting large and saying they're a Medicare patient, or they're a Medicaid patient, or they're private pay, or we have our MAP funding here, which is the county assisted health insurance. It really takes picking it up and looking at the card. Now, with our health record software, once you put their billing information in, if you put their insurance information in, you've run on them a second time and you pull them up, that information will be there as well. But it does take an education component to say, this is offered through WellMed. WellMed is a potential client. For our WellMed is one of our partners, and to have the crews look for that. Now, one of the other aspects is, because of our partnership with WellMed, sometimes we'll get into a situation where one of our patients needs primary care. They have not established primary care. And so at that point, we're able to refer them to WellMed and say, call this phone number if you need primary care. We can give them a list of 3 or 4 different places to call for primary care. But it does make it a lot easier to try to get them on the right track with primary long-term care. Gotcha.
So we have a lot of questions coming in, and they're all fantastic, folks. You guys have some great questions. For Stephen and Dr. Navarro, are you okay with going a little over the hour mark? Are you around, or maybe 5 minutes extra? We have a lot of questions that want to get answered.
Yeah, I'm good.
It's okay with me.
Okay, great. I just want to double check. So the next question is, and folks, keep them coming too. These are great questions, seriously. What happens when the patient who would qualify for patient status is not a patient in the clinic system?
I'll let Dr. Navarro answer this because it happened 2 weeks ago.
Yeah, so just to clarify, the question is what happens if there's a patient that's not part of WellMed that gets transported to one of our clinics, or did I misunderstand the question?
Yeah, that's it. Mm-hmm.
That's it. Yeah, so it actually happened. Part of the reason when we were putting the program together is exactly that scenario, right? We want to make sure that the patient has a good experience, whether they're our patient or somebody else's patient. So having that layer there where the Pulsara notification comes in with the patient's information, we can check on our computer system, EMR, to see if they're really part of our clinic or not. And we can direct the crew on the scene and tell them, oh, sorry, that's not one of our patients. Or no, in this particular scenario, there was one patient that was part of one of our providers that was not at that particular clinic, but part of WellMed. So we ended up seeing the patient anyway, treating them and getting them follow up with their primary care provider that's assigned. They hadn't met their primary care provider. A lot of patients sign up for insurance and don't even know who they're assigned to, right? So this was the case with that patient. They didn't know who to go to. They just needed help, and we were able to provide that assistance and get him kind of situated.
Gotcha. Thanks for clarifying that. There's data suggesting that paramedics are not really good at determining who should or should not go to the ED. Have you found this to be true? Also, will you be publishing any literature on this, and maybe in GEMS too?
Yeah, this is a great question. And so the way that we have addressed this is that we've put multiple layers into the system, okay? The first layer is going to be the triage of the 911 call is actually triaged by EMTs in our department. They are certified. That's your first layer. The second layer is the C4. Now, the C4 has had extensive training beyond a regular field crew and what we call red flags. And red flag training is provided by our medical direction, where they address the things that can kind of come back and bite you if you don't pay attention to them. Those are the things that'll sneak up on you because you might see it as something pretty minimal, but in actuality, it's something that could be life or death. And then the third thing is there is not a decision made about whether you go to the hospital or not with treatment in place. We're not talking about, your standard patient refusal, and there's no alternative transport that doesn't start with a telehealth, right? So the final layer that we use to protect ourselves and our patients is that everything starts with a conversation with the doctor. If we're going to go to Dr. Navarro's clinic, our conversation is with him. If we're going to transport to a pain management clinic, that's going to start with a conversation with our medical directors. I don't know if y'all can tell, but throughout this conversation, we keep our medical directors extremely busy. The other thing that has come up out of this that's very interesting is that this model also works very well with high-risk refusals. If you have someone to call to provide some sort of resources, whether it's telehealth or, anything that could be considered treatment in place, where formerly, if you had a patient that was a high-risk refusal that would not go to the hospital when they needed to go to the hospital, and you may have encountered this with your COVID patients over the past year and a half, there is a fear, especially of elderly COVID patients, of going to the hospital and dying in the hospital, and they are so adverse to that. In this model, you are able to provide them some sort of treatment. Where normally you would get the high-risk refusal and you would leave, and the outcome, who knew? With this model, you can now do a telehealth. You can prescribe medications. The C4 will facilitate those medications being delivered to you, or will go pick them up themselves. And we have a follow-up system that maybe you don't have in your department right now. Any call, whether it's a high-risk refusal, whether it's a treat in place, whether it's a telehealth, has the opportunity now for a medical professional to follow up with them. All you have to do is call the C4 and say, this guy's going to need a follow-up. So we've tried to build in as many layers of protection as we can into the system. And as far as, are we going to publish the works? Yes. Our Office of the Chief Medical Officer, which is our medical direction here in Austin, Texas, is going to write a paper on it. I'm sure they'll be published. They're very good authors. They're very smart people.
I'm going to take the next two questions from two users and make it one question. Do you run this 24/7, and how's it billed?
Okay. During a crisis, we are 24/7. Now, in between crises, we operate from 7 a.m. to 10 p.m. The best thing about this team is that it's like breathing. You can expand it out and you can shrink it back depending on what the situation is. If we have another hurricane or another ice apocalypse, we can breathe out quite easily. We try to keep people trained up that maybe not be assigned full-time to the C4. Keep them trained up, keep them participating. We have a couple of different ways to make that happen so that if we need to bring them in, their spin-up time is very short, to kind of get back. The thing about the C4 and the thing about, and what we're doing, it changes so fast. It changes directions, just on a dime, and so you have to keep the education up. It's very, very important.
I hear you. And speaking of C4s, who staffs them? And are they doing other tasks with like 10 patients a day?
Okay, so the C4 is currently staffed with clinical specialists. Clinical specialists are paramedics in our system, and it is their full-time job. They are assigned there. They do not have split assignments. Then we have people that we have trained up that work in the field, and they'll come in and help cover shifts and whatnot. The team does a lot. It does all of this treat and place models. It does all of this they do all the follow-ups. And then they also handle a lot of the COVID aspects of our department and of our city. So they have a really big job. And it's pretty busy up there, especially in a crisis. If we have a COVID wave, it's pretty nuts.
I bet. So that's about what we have for today. But I want to give you guys both a chance to offer any final words.
I really think that this is the future. And I think Dr. Navarro, if you're still there, he'll agree with me. The you call, we haul era, I think, has ended. It's definitely different than when I got into this. We really have started to accept our position in the healthcare system where it's not going to be just about taking people to the emergency room. The large chunk of what we deal with is going to have another option.
Yeah, without doubt. Anything for you, Dr. Navarro? Or do you leave? Okay, well, I think you left. So I want to thank you again to our viewers for joining us today, and to our sponsor, Pulsara.